Thank you, April, for that introduction. Again, I'm KMARX, Director of the Division of Tribal Affairs at CMS, and I was asked to provide information about Medicaid, and in particular Medicaid expansion, and to talk about what happens if a state does not expand Medicaid. So I'll go ahead and go through my slides, but as Stacy indicated, if you have questions, don't be shy. We really do have a lot of experts in the room. Across the United States, the Indian population is very small, but the issues can be really complicated, and we know that they're complicated, and that's why we work very closely with the Indian Health Service, with Stacy's office at HHS, and with the NIHO project to provide information about Indian health issues and the new CMS programs. So first of all, I just want to kind of step back and remind people what Medicaid is. Medicaid is a state-operated program that provides medical and health services to low-income and needy individuals and families. It is state-operated, so the state does determine who is covered, how the providers are paid, and what services are covered. And CMS, in the Center for Medicaid and CHIP Services, provides oversight of the program. We provide technical assistance, and CMS provides federal matching dollars to the states for Medicaid reimbursements. For the Indian Health Service facilities and facilities operated by tribes under 638, CMS reimburses states 100% matching funds. And just to remind everybody, for instance, if an IHS hospital provides services to an individual that's enrolled in Medicaid, it's a Medicaid covered service, the Indian Health Service bills the state for those services provided. The state reimburses the IHS hospital for those services, and then the state files a claim to CMS for those services, and then the state receives 100% federal dollars. They receive full reimbursement back for those services that they had reimbursed the IHS for. Okay, and currently under Medicaid there is a OMB rate. We call it an OMB rate, an all-inclusive rate, an encounter rate, and that is published in the Federal Register on an annual basis. And that, I think in nearly all states except maybe one, is how the states reimburse IHS and tribal facilities, both for inpatient and outpatient services. And then who is covered under Medicaid? There are some mandatory categorically needy groups: children and families, pregnant women, disabled, and the elderly. The states have the option to create additional groups. Some states have established a spend down program, and now, because of the Affordable Care Act, states have another option of expanding Medicaid to childless adults ages 19 to 64 who are below 133% of federal poverty level. Under the Affordable Care Act, the states must provide essential health benefits as minimum standard coverage. They do have the flexibility to add additional benefits and additional groups, as I mentioned, but they must provide a full range of Medicaid services to the elderly, the disabled, pregnant women, and the children covered under the EPSDT program. The last group, these are your traditional Medicaid. This, before the Affordable Care Act, these individuals, the elderly, disabled, pregnant women, and children, were the only ones covered by Medicaid until the Medicaid expansion rules. So now, under the Affordable Care Act, states have the option to extend Medicaid coverage to, sometimes you hear the term childless adults, non-pregnant adults, but these adults are ages, again, 19 to 64, with incomes up to 133% of federal poverty level. For a family of four, that's about $31,000 a year. The states receive 100% federal funding when they provide services to these individuals. It will gradually reduce to 90% federal funding in 2020. States can decide when to expand. There's no deadline. And they can expand, and then they can, after perhaps the federal funding is reduced, they can decide to drop coverage in the future without federal penalty. originally when the Affordable Care Act was passed, the law as written and passed by Congress required states to extend Medicaid coverage to this group. But because of the U.S. Supreme Court decision in June of 2012, the U.S. Supreme Court decision said no. They upheld everything else about the Affordable Care Act, including the individual mandate, but they said no, states cannot be required to expand Medicaid to this group. So now we're in the situation of some states expanding Medicaid and some states not. And this is a map of the states that have expanded or have not expanded Medicaid. There are 25 states and DC that have actually expanded Medicaid. The states in blue are the ones not expanding. And you can find your states. I think there's some representatives from Alaska and Montana. Montana is one state that has not expanded Medicaid. South Dakota has not expanded Medicaid. There are some states that are considering it now, such as Virginia, New Hampshire, and Utah. So there is no deadline. States can decide later to expand Medicaid. I know that there's a ballot initiative going on in Montana right now. I believe Lisa Evers was here at NIHB a couple days ago to talk about that. They hope to have a ballot initiative on the ballots for next November for the residents of Montana to decide whether they want to expand Medicaid. In April, I sent. Okay, April passed out this document called Medicaid Expansion Status and Estimated Financial Impact, and it lists the states that have not expanded Medicaid. And this shows the money that the states are leaving on the table. This money could be available to them to provide services to their citizens, but for those states that have not decided to expand Medicaid, they're not drawing down this money, and this money is being left on the table. So you can, if you want,
Can I ask a question? I'm sorry, that was the first time I heard that a state could opt out after they opt in. Is that
no, that's always been there. Yeah. So that's kind of been the encouragement. I mean, for the first 3 years, the states receive 100% federal dollars, and so when CMCS talks to states, they say, well, you can implement it, and then if you decide later on to drop it, you do have that option.
So the political reality, I think, for a lot of individuals, though, for leaders in states, is they're worried about getting all these individuals on insurance, and then dropping them 3 years later. Then you're going to have this group of individuals that are uninsured. So, right, that's the political reality.
Right, right.
But get your states, go to the House, go to your state capital. Really encourage them to think about it.
All right, thanks, Jeff. And actually, it's great news that over 7 million people have enrolled in the marketplace, but that doesn't even count, over 9 million people who have enrolled in Medicaid since October 1st. A lot of these are renewals, but what we're finding out is that because of all the outreach about the marketplace and enrolling, in the marketplace, people are applying for the marketplace under this one streamlined application and finding out that they are in fact eligible for Medicaid, and they had been eligible for Medicaid all these years. They just never applied before. So that's good news too. And then just while I have the map up, Michigan has expanded Medicaid, but they have a unique program where Medicaid beneficiaries will be enrolling in managed care plans that they have. There are protections for American Indians living in Michigan that they will not be mandatorily required to enroll in the managed care plan. They can voluntarily opt in, and all of the protections, such as the cost-sharing protections for Indians under ARA, which I'll talk about in a little bit, remain, and that they can continue to receive services from their tribal clinics up there. In Arkansas and Iowa, they adopted a premium assistance model where those beneficiaries who would otherwise be eligible under Medicaid, they're going to be enrolled in the marketplace, but their premiums will be paid for. But that still counts as a Medicaid expansion. So there are some models for states to consider if they just don't want to enroll or expand their Medicaid program. And in fact, with the Tribal Technical Advisory Group at CMS, we're exploring ways as well to see if we can develop possible waiver to try to address the issue of individuals, American Indians, Alaska Natives residing in states that have not expanded. And so again, just to remind everybody who is covered under the Medicaid expansion, when we say childless adults, it doesn't mean that you don't have children. It's just your children have grown and left. You know, sometimes states don't cover women only if they're pregnant, so this would cover all women, whether they're pregnant or not. There's a lot of older people that are not quite eligible for Medicare. You know, if you know, the age group of 19 to 64, those individuals will be covered. And then younger people without families. And that includes a lot of young Indian men, or, you know, or old Indian men that maybe have never applied for Medicaid before. And they're a new group, and you know, they're a hard group to reach, I know, because they can get services from their Indian Health Hospital or the tribal clinic, but you know, they're your seasonal workers, they're your firefighters, you know, your rodeo guys. You know, they could be injured. They could be injured off, you know, out of state, away from their IHS hospital or clinic. So for those states that have expanded, this is a good option for them. So this was what was intended for those states that have expanded and how it interplays with the marketplace subsidies. Medicaid goes up to 133% of federal poverty level, and then you can go into the marketplace. And then, of course, Medicaid and CHIP continues to go up to a higher level, about 240, 250% of federal poverty level in each state. But then this chart is very interesting because this is where you see the coverage gap. For those states that have not expanded Medicaid, you can see over on the left, below 100%, that's where the coverage gap is. Those individuals are not eligible for Medicaid. It does vary from state to state for working parents and jobless parents. But the big crux is those individuals below 100% of federal poverty level. We call that a coverage gap because they can enroll in the marketplace, but they don't get any of the marketplace subsidies. Individuals between 100 and 133% can enroll in the marketplace and receive the premium tax credits, but those below 100% of federal poverty level will be paying full premiums. So again, an individual at 100% of federal poverty level, that's about $3,892 a year. I mean, this is the poorest of the poor that are falling in this coverage gap. And like I said, they can go into the marketplace, but they're going to pay full price of the premiums. Now, some tribes have elected to pay premiums on behalf of their tribal members, and so in those states, such as Wyoming and Montana, where Medicaid has not expanded, maybe tribes might want to think about paying premiums for these individuals as well, but that would be a tribal decision. But if an individual does fall into this coverage gap, they can file an exemption. The tribal exemption, the hardship exemption for individuals eligible for services from the Indian Health System, but you can also file an exemption if the premium is larger than 8% of your household income, or if you applied for Medicaid and you were denied Medicaid because your state did not expand. So if you know individuals, if you're working with individuals that fall under this coverage gap, they don't want to pay the premiums because they do have access for the Indian Health Service, or they just can't afford the premiums, they do have the option to file that exemption. Now, and when you're talking about the poorest of the poor, if an individual does not earn enough money to file an income tax return, then they're not subject to the hardship exemption, the tax penalty. I mean, so just a reminder. So, but I just want to kind of pull back and even in those states where Medicaid has not expanded, Medicaid still remains a very, very important program. For Medicaid and CHIP, you can enroll at any time. There's never been an open enrollment period. So the March 31st deadline, that deadline is for the marketplace. We've worked over the years to require states to accept tribal documents as proof of citizenship. Proof of citizenship is required for all Medicaid applicants now. That's something that was enacted back in 2005 under the Deficit Reduction Act, and really since 2005 we worked with CMCS to issue regulations, and it was corrected under the CHIPRA authority that tribal documents, these are tribal enrollment cards, tribal membership cards, a letter from a tribe, that basically has the equivalence of a U.S. passport, that tribal documents can be used for proof of citizenship and identity for purposes of Medicaid and CHIP. The Streamlined Application is intended to make the application process simpler. All those old rules, except for the elderly and disabled, a lot of those old rules about how many cars you can have, that's all gone. We're using the modified adjusted gross income, similar to the marketplace. This is the same income basically that you would report on your federal income tax return. So I know we have a lot of questions, of the tribal income, what income should I be reporting? And the basic rule is that if you're not reporting certain tribal income on your federal income tax return because it's not taxable, then you don't report it on the application. We do have an Appendix B that is part of the application, and this Appendix B was developed specifically to capture information about American Indians and Alaska Natives. It asks questions whether you're a member of a tribe, whether you utilize services from the Indian health system, and those questions are very important because of the special protections under the marketplace for tribal members. Yes? Okay. So what you're saying, in order for them...
So let's say somebody is making $11,200, and so they're just shy of like $300 over, being over that 100% of federal poverty. If that tribal income will benefit them and get them over that and make it like 12,000, would they be able to?
So they could qualify for the subsidies? I've never heard that question, but let me just, for the audience, let me just repeat that question. So if you don't report your tribal income and your income is below 100%, you don't qualify for any subsidies because of that. If you want to report your tribal income so that you are above 100% of FPL in order to qualify for the subsidies, should you do that? And I... That's what the general counsel advised? Okay.
And if it's not going to benefit them, they don't have to report it.
Okay. I'll... Huh? So like the gaming is taxable. I'm talking about like the trust, like the IAM account money, a lot of the fishing rights we've heard, like in the Washington, any income derived from fishing rights. Okay. Yeah, well, I'll take that question back and just verify and see what, our Medicaid folks say. The thing with the Streamline application is that you've heard about this data hub, and the data hub does what it does. It pings up against, any income, IRS information, and Social Security. Go up against your Social Security. So there's going to be, a ping. So. Yeah. Okay, we'll keep that on our list of questions to IRS. So.
Is there a difference in income for eligibility for Medicaid as opposed to the marketplace?
Is there? I'm sorry. What's the question again?
Difference in Indian income and how it's treated for purposes of Medicaid and the marketplace?
Yeah, that's why we created that Appendix B. And sometimes it doesn't matter because some income is not taxable for IRS purposes and is not countable for Medicaid purposes. Your trust income. Um, but in the event you do have income that you would report or is taxable income, it might not be counted for Medicaid purposes, and so that's why we created that Appendix B, because certain monies are clearly not counted. One example that we use is, if you're an Indian jeweler, you're a self-employed jeweler doing Indian work, you might report that as income because you're self-employed, but for Medicaid, there's an exception that if you sell things that have cultural significance, you can deduct that income for Medicaid and CHIP purposes.
But that's not deductible for marketplace.
No, no, there's not. That's taxable income. Yeah. SS what? SS? I don't think that is right. I know for Magi they add some.
Okay.
So what I've ran into is parents with children with disabilities. Okay, so do they count the children's disabilities as their income?
I don't think they do. No, they should not. Okay. Any?
Because the opposite, it's trying to get to the opposite thing here, where you're always trying to have low rates, but really qualify. So we can qualify to get the premium tax credit, which is the marketplace, so.
Yeah, that's.
For a loop,
I know that's an interesting question. I haven't heard that before.
So if you're trying to get them past that 100%, you can't use the SSDI?
I don't know. That's a whole separate program. Yeah. Yeah. Well, I always appreciate coming out and doing these presentations because I always learn something. And we were at the CMS ITU trainings this past week with all the business office coordinators and managers, and we had a lot of good questions there too. So, yeah.
do gifts count?
Huh?
Do gifts count as income? I'm just wondering if there's some way I tried for people below to know. What if it's travel?
You can, yeah.
But there's plans for $177, which would be $1,700, $2,000 for tribal has to pay $2,000 for a yearly premium. That might be a better option than trying to get them to
But what we saw too was that some tribes are actually being, having a financial benefit to themselves for taking the penalty rather than offering the insurance.
the tribe.
As tribal governments,
As tribal government.
as tribal governments as a large employer. Yeah, that's a separate issue. I know that some tribes are paying premiums for individuals, and I don't know to what extent that's being done in this area in Montana, South Dakota. So, okay.
We only have one tribe that is able to do that based on the Medicaid, but IHS took all the other tribes.
So you only have one tribe.
Yeah, that is tribally operated. They can do it, but they haven't chose that yet.
Pay sponsorships, pay premium, sponsor tribal members. But I just for people, so there's one tribe that is actually doing it. I'm trying to.
No, there's one tribe in Montana that if they wanted to do it, they can do it.
Oh, okay.
CHS funding, I guess, but or it's not CHS funding, it's created. But there's only one tribe in Montana that has that option.
Okay.
Currently, yeah.
But a tribe could take over a CHS program if they wanted to and use the CHS dollars to purchase premiums for their individuals, for their tribal members in the marketplace. Okay. And another reason that Medicaid is still important is because of a lot of the Indian protections in ARA remain in effect. ARA is the American Recovery and Reinvestment Act that was passed in 2009, and there's a section 5006 that's called Indian Protections for Indians under Medicaid. And CMS implemented that through a state Medicaid director letter. We went through extensive tribal consultation back in 2009 and 2010. Sometimes people get confused that they think that these protections are new to the Affordable Care Act, but these have been in existence for 5 years now. 5 years, and we know that there's still some confusion. Some states are not applying these rules always correctly, and it's always helpful to know about if there are problems or issues regarding how the states are calculating some of this tribal trust property. And within CMS, I forgot to mention, we do have a good resource at each of the CMS regions, your Native American contacts, and they really are your first point of contact if you have questions that are specific to your state. So let me go over some of these ARA protections. These are the resource exemptions. Property that's held in trust is not counted. IAM account money is not counted, whether it's restricted or unrestricted. Monies paid out from exempt resources are exempt, and they're not counted in the month of receipt. But under the Medicaid rules, if you receive money from one of these exempt resources, such as fishing income or whatever, and if you spend it in that month, you're okay. But if you take that income from an exempted resource, such as fishing, and put it into a checking or savings account, it will count that next month for Medicaid purposes. Sometimes that's a little bit confusing. Additional resource exemptions, this is all from the Section 5006 of ARA, is property located on a reservation, even if the boundaries no longer exist. Any real property improvements, ownership interest in rents, leases, royalties, usage rights, and again, resources from natural resources, the fish and shellfish, any harvesting of animals, plants, or timber. Also excluded are items of religious, spiritual, traditional, cultural significance, and that's where we get that exception in Appendix B. If you sell any of these items of cultural significance, it's not counted. And then again, any monies received from any ownership of these rights from these excluded resources, they're not counted in the month of receipt, but they may be counted as a resource the following month. In general, there's really nominal, very little cost sharing under Medicaid. Children under 18 cannot be charged cost sharing, but there's specific exemptions for American Indians, Alaska Natives who utilize the Indian Health System and Contract Health Service. They are exempt from cost sharing, and the cost sharing includes exemption from premium and enrollment fees, and any coinsurance, deductibles, or copayments. And it's very interesting the way Section 5006 of ARA was written. It just uses the term Indians. Indian wasn't defined. And so, working with the Indian Health Service, we were able to publish regulations that defines Indian for Medicaid purposes, very similar to the definition of Indian that the Indian Health Services uses for eligibility criteria. So it's a broader definition of Indian than you find in the Affordable Care Act for the special protections for members of federally recognized tribes or Alaska Native shareholders. Those protections such as the special monthly enrollment period that's only for members of federally recognized tribes, and the cost sharing reductions up to 300% of federal poverty level. That's only for members of federally recognized tribes and for Alaska Native shareholders. But the cost-sharing exemptions for Medicaid is the broader definition of persons eligible, basically persons who are eligible for services from the Indian Health Service. And then another important part of Section 5006 is prohibition or an exemption from the Medicaid estate recovery rules. Medicaid is allowed to file liens on persons' estates for recovery of Medicaid services, but certain property owned by American Indians and Alaska Natives are exempt from that Medicaid estate recovery. And again, this is very similar to the same property that's exempt for eligibility determination, trust income located on the reservation, including any, leases, your IAM accounts, and again, the natural resources. If you're an Indian and you own fee simple property on the reservation, that can be recovered under the Medicaid rules. We're talking about trust property here. And then again, items of religious or cultural significance cannot be recovered under the Medicaid estate recovery rules. And then any ownership interest, remainders in estate, like if you have like a person's estate money in an IM account, they cannot put a lien on that IM account. And then under 5006, there's protections for Indians for those states that develop Medicaid managed care plans. American Indian Alaska Natives can choose to continue to receive services from an IHS tribal or urban site even if they're enrolled in a managed care plan. The managed care plan must pay the Indian Health Service tribal or urban clinic at a negotiated rate, and it cannot be less than the normal payment rate that they would pay participating providers. And if that rate that's agreed to is less than the normal state payment rate, then the state has to make up the difference. Under Medicaid managed care or managed care in general, you usually receive lower reimbursements. So maybe, and they're usually capped, so maybe the Medicaid managed care will reimburse the IHS or tribal clinic at $100, but the all-inclusive rate, I think, for outpatient right now is above $300. The state has to make up that difference between $100 and $300 and reimburse the Indian Health Service tribal and urban clinic for that payment. And as I was explaining, with a lot of even those states that have expanded Medicaid using the marketplace for Indians are not mandatorily enrolled in these managed care. They have the option to enroll in the new managed care programs that are being established in Michigan and Arkansas and Iowa, or they can choose to continue to receive services from their IHS tribal or urban clinic. And even in Arkansas, there are no IHS tribal or urban clinics located in Arkansas, but a lot of tribal members from Oklahoma travel back to the hospitals like Cherokee Hospital, and Arkansas will be reimbursing those Oklahoma hospitals and clinics, tribal hospital and clinics as well. And then under Medicaid, there's a very specific tribal consultation requirement when states make changes to their state plan, whether they do it through what they call a state plan amendment or whether they do it through a waiver proposal. They are required to seek advice from, and this is in the statute, from the Indian Health Service, tribal, and urban Indian healthcare provider located in that state. And all the states that have ITUs located in them, it's a total of 37 states. That includes some of the urban programs such as Maryland and Illinois. There's a clinic in Hawaii that provides services to American Indians, Alaska Natives, and they receive IHS funding. Hawaii was required to have a state plan amendment, and this state plan amendment is specific and describes what the tribal consultation policy is for Medicaid changes. So those are all on file, and in fact, those are all on the CMS, American Indian, Alaska Native website. And at the regional level, when a state does propose a state plan amendment, those state plan amendments are reviewed at the regional level, and one of the first boxes to be checked is, was there tribal consultation? If there wasn't, that state plan amendment is returned to the state. So within Medicaid, we take tribal consultation very seriously at the state level, and in general, at CMS, we take tribal consultation very, very seriously. And then there are additional Medicaid provisions that are longstanding. As I indicated earlier, the 100% federal financial participation, that's the federal matching rates, are 100% for services provided in IHS or Tribal 638 clinics. Urban and tribal health clinics can participate as FQHCs, and they can choose to receive a cost-based reimbursement. And tribes and tribal organizations can enter into agreements with states to provide what they call Medicaid administrative match for outreach activities. They conduct certain outreach activities, and then they can draw down their expenditures and receive reimbursement for that time spent. So there's a lot of good things about Medicaid. It is unfortunate that some states have decided not to expand Medicaid, and I think this map is very, very interesting. But I think that as the states continue to look at the uninsured, maybe some states wanted to wait and see what the marketplace looked like, as I indicated, Virginia, New Hampshire, and Utah are considering Medicaid expansion. Hopefully the ballot initiative in Montana will go well. I was talking to some of the state Medicaid folks from Wyoming. They were not very positive. They do not see Medicaid expansion happening in Wyoming anytime soon, unfortunately. But anything that you can do to encourage your state to expand Medicaid, I think it will be tremendously beneficial to the tribal communities. That's where we're seeing a lot of the Indian populations, and you're probably seeing it more, on a day-to-day basis than we are in DC and Baltimore, but that's a huge coverage gap for those individuals falling below 100% of federal poverty level. They really are the poorest of the poor. So, are there any other questions, or I think we have a little bit more time. If there's other questions that, you've even encountered, in helping people with the marketplace, we can try to answer them, or at least we can take the question back to DC. Yes.
I have a question. When you sign up, because I was given this question. When you sign up and you live on the reservation, one of our councilmen was told they still have to get an IHS referral to go somewhere else.
No, if you enroll in a QHP, and if your income is below 100 to 300% of federal poverty level, then you enroll in what they call a zero cost sharing plan, then you do not need to have a contract health service referral. You can self-refer. And it's my understanding that the cards are being, some people indicated this past week that they've even seen the card and it says zero cost sharing, so that you do not need a contract health service referral in that instance. If you're between 300 to 400% of federal poverty level and you see a non-IHS provider, then you will need a contract health service referral. Okay, any